Good afternoon and a very warm welcome to today's webinar, Mosaicism, the Power of Knowing. I'm Emily Austin. I'm the General Manager of Cooper Surgical Fertility Solutions in the UK, Ireland and Germany, and it gives me great pleasure to welcome you to join us for this webinar today. We're very much looking forward to this webinar. We've had a bumper number of delegates sign up and we've got a great lineup of speakers for you today. Firstly, joining us, we're delighted to have our colleague, David Chrimes, who will be explaining what mosaicism is and the basics of mosaicism. David is a PhD molecular geneticist with 16 years experience in reproductive health molecular diagnostics. After working for leading UK research institutes, he joined Bluenome in 2005 and Cooper Surgical in 2016. As Director of Global Genomics Business Development, David continues to drive future innovation in the genetics of disease within the Life Science and Innovation team here at Cooper Surgical. Also joining us today, we have a regular webinar panelist. Dr. Tony Gordon is a PhD molecular cytogeneticist with over 20 years experience in molecular diagnostics. After working at the Institute of Cancer Research in the UK and in diagnostics, he joined Bluenome in 2006. In 2013, Dr. Gordon joined Genesis Genetics, a leading global company for PGT-M, SR and PGT-A, where he was the managing director for the 5 Genesis Genetics USA laboratories, plus laboratory director for the 2 Genesis Genetics UK laboratories. In April 2016, Genesis Genetics laboratories were acquired by Cooper Surgical, where Dr. Gordon is today the Director of Clinical Operations for the UK labs and the Global Vice President for Business Development for Life Sciences. And Tony is updating us today on the latest mosaicism research. We have a very special guest today. We're extremely pleased to have Dr. Bart Kuczera join us from Beacon Care Fertility in Dublin. Dr. Bart studied medicine in Poland and attended the Royal College of Obstetricians and Gynecologists courses in London as part of his reproductive medicine subspeciality training. In the early days of his career, Dr. Bart combined his interest in theoretical medicine and clinical practice. After obtaining his specialist qualification, he practiced in the Department of Gynecological Oncology, while lecturing human anatomy to medical students until 2010. Dr. Bart's special interests in fertility include premature ovarian aging, male factor infertility, endometriosis, embryo implantation, and pre-implantation genetic testing. Thank you so much for joining us, Dr. Bart. If you have questions as we go through the webinar, please do enter them into the Q&A box. We'd love to get your questions, so please ask away. David, welcome. I'll now hand over to you.
Thanks, Emily. Thanks for the kind introduction. Lovely to be here today on a lovely sunny summer day. So today, as Emily just said, we'll be talking about the power of knowing about your mosaicism in your embryos. I'll be starting, and then Tony will be doing the second half of the presentation. So really, I'm just going to do a very brief introduction to where you will see mosaicism in PGT, a very brief overview of PGTai2, but then a bit more detail on how that accurately detects mosaicism and how we report it and why. And then Tony is going to jump in and talk about the very latest evidence of mosaicism. And then after we've had the summary, we'll go to Dr. Bart to talk about his experience. So when we think about mosaicism, generally we think about PGT-A, so the pre-implantation genetic testing for aneuploidy. So this is screening embryos for chromosomal abnormalities. It's an option for all IVF patients with the stated aim of improving IVF success rates per embryo transfer, ensuring the highest quality embryo comes first. And the key thing is it doesn't require any kind of personalized test prep. So it is, whether you choose to use it for all patients is a different question, but it's available for all patients. It's worth noting that at CooperGenomics, we run this PGT-A testing on every single PGT test we run, even if it's PGT-SR or PGT-M, as well as looking for the genetic aberrations caused specifically by the genetic rearrangement or structural rearrangement for an SR case, or in the case of PGT-M, looking for the inheritance or lack of inheritance of that single polymorphism or the genetic disorder. On top of that, by default, we run the whole PGT-A aneuploidy screening because, in our opinion, there's no point transferring an embryo which may be normal for the abnormality that it came in for, but contains a whole structural aneuploidy somewhere else. So although we generally think mosaicism and PGT-A, you will see those results on every PGT test that comes in to Cooper. So, PGT-A has developed a lot over the years. So as Emily started in the introduction, I was really got into PGT-A as we were developing the test in 2007 and launched it in 2008. And this was single cell, black and white. It's either aneuploid or it isn't aneuploid. It's euploid or aneuploid. Then by the time we got to 2014 here, then the world had really moved on, and it's important to consider that two tracks were happening in parallel. One, the testing technology for PGT-A, the arrays and then sequencing, was evolving very rapidly. But at the same time, people were much more confident in growing embryos to day 5 at blastocyst stage, doing a trophectoderm biopsy, vitrifying the embryo while the results were generated. And once you start taking multiple cells, we started really uncovering the level of mosaicism in the embryos. So really there's a parallel track here between the testing technology advancing and the ability of and confidence in IVF clinics to take these embryos to day 5, do a biopsy, vitrify them ahead of transfer. So really what we've been doing at Cooper is trying to push the technology to really get the most accurate mosaic detection possible, and by doing that, by increasing the amount of data that we generate. So when we think of an embryo, excuse me, a chromosomal health of an embryo should be that when we test an embryo, it's a euploid embryo. Now, by euploid, we mean that it has the correct number of chromosomes. So chromosome 1 to 22, these chromosome pairs, you'll see they're all in pairs, are your autosomal chromosomes, and you should have 2 copies of these. A text, kind of intrinsically think of one from mum and one from dad. So all of these chromosomes pair up, and then for your sex chromosomes, you either have 2 copies of X or an X and a Y. Now, depending which country you're in, certainly in the UK and Ireland, we don't release these results, but we do test them. And if there is an abnormality on the sex chromosomes, we let you know. So, but these euploid embryos have the correct number of chromosomes and have been shown to have the highest likelihood of a successful pregnancy. Not guaranteed, but the highest chance of a successful pregnancy. The complete reverse of these, in a sense, is these aneuploid embryos, where they have an incorrect number of chromosomes. Now, PGT-A has been going on now for many years, and we now know that there isn't an age range where aneuploidy isn't seen. So it doesn't matter whether it's egg donor, sperm donor, maternal age, paternal age, they're all likely to suffer at some point within a cycle from aneuploid embryos. But we do know that this is increased by maternal age. So the higher the maternal age, the higher the risk of aneuploidy. Now, aneuploid embryos may result in a failed implantation, so you just don't have an implantation event. However, it's now been shown, and Tony will talk about this a bit later, that even if they're aneuploid, they can still implant, but then they will miscarry most likely. So unfortunately, just being an aneuploid embryo doesn't in itself always stop implantation, but it will almost certainly lead to miscarriage and the potential of genetic disease. And here we've highlighted chromosome 10 being triploid. There's been no reported live births of a full trisomy 10 child. So we know that if you were to transfer this embryo, it would have a negative outcome. It would either fail to implant or it would miscarry. Then what we discovered was these mosaic embryos. So mosaic embryos are where the embryo has at least 2 distinct genetic cell lines within it. So you have a mixture of these euploid and aneuploid cells. Now, when we biopsy, and I say we, the IVF clinic biopsy the trophectoderm, they're taking a cluster of these cells from the trophectoderm, tubing them, and then we report out the ratio effectively of these euploid to aneuploid cells. What we don't know from a trophectoderm biopsy is whether this mosaicism is seen without the entire embryo, including the inner cell mass, or whether the inner cell mass is completely euploid or aneuploid. We are taking the trophectoderm biopsy as a representation of the whole embryo. So that is the limitation of the biopsy. But what we do know, and again, Tony's going to really be talking about this a lot more, is that mosaic embryos, yes, they implant less, yes, they miscarry more, but, and there's quite a lot of documented evidence now, they can lead to a live birth, and so should be considered for transfer, assuming there's no euploids and the correct counselling has taken place. But this is why we believe very strongly that by identification of these mosaic embryos, we can really inform patient choices, embryo prioritisation, best first, and then work down. But you certainly, this information is useful for patient management. In terms of PGTai2, we launched, as I say, this was launched in 2019, and then we did an update in March 2020. So 2022, so just a few months ago now, with some new high-powered sequencing. But all I want to say, because we have lots of other technology talks, I don't want to go too much into the technology. We do produce a lot more data now, 20 times more data than we were doing initially, and that's all around accuracy. We're just trying to really improve the accuracy, both generating both CMV and this global SNP for a dual analysis for the aneuploidy detection. This is just a representation for this talk. We don't actually look at this in the lab. We don't get access to this kind of imagery. But under the hood, in the AI algorithm, it's combining what you may consider to be a classic CNV copy number chart with a SNP quantification as well. So you would expect to see where the trisomy here, a triploid chromosome here, extra amount of SNP dosage. And what this does by combining these two metrics is really it rejects noise and reduces artifacts. And when I say reducing artifacts, what we want to do is when we say it's mosaic, it is mosaic. It's not just an artifact of the technology. So really increase the technical accuracy and reduce artifacts. And when we talk about best-in-class mosaic calling, we just mean it's most accurate mosaic calling out there. Again, very schematic drawing here, but this was all validated using lots of unique samples, 270. We get lots of cases through the CooperGenomics laboratories of translocation cases, other cases where we know exactly what the genetic outcome is, and you can do serial dilution and titrations and plot out through all these replicates where you would expect these titrations to fall. And this gives us a great baseline in statistical analysis, so that we're really using statistics and not visualization to map out these changes. And then we bucket the data. So this matches the PGDIS guidelines, that below 20% is euploid. Between 20 and 40% mosaic is low-level mosaicism. So anything that falls within this range here is a low-level mosaic. We then have the high-level mosaics, which are 40 to 80%, and then anything above 80% is aneuploid. So just to put that in a bit more clarity, so these are our euploids. And the reason, which are less than 20%, and these have the highest chance, low-level mosaic, medium, high-level mosaic, low, unlikely, and aneuploid. Again, Tony's going to be talking about this. very low, very unlikely chance of success. So from a Cooper side, these are our basic numbers from all comers, all patient ages, everything is there. Worth noting that the majority of embryos across all age ranges come back euploid. If you then consider transferring low-level and high-level mosaic, you've got another 13–14% of embryos, so up to potentially 58% of embryos across the board suitable for transfer. So, you know, there are a lot of embryos here potentially suitable for transfer, assuming that you are prepared to transfer mosaics under the right circumstances. And this is just some of the categories that we report. So I'll start from the bottom. Sample ID 6, euploid, none. This is normal. This would be your highest priority embryo for transfer. Sample ID 2 is kind of like the reverse. It's aneuploid. It's got an extra copy of chromosome 18. It's abnormal. Probably wouldn't consider that for transfer. If we look at mosaicism, for this chromosome, this sample here, it's mosaic, whole chromosome plus chromosome 6 mosaic. That's low level. So that means it's between 20 and 40%. If we look at sample ID 1, it's mosaic. There are 2 mosaic changes. And its own interpretation is high level mosaic. So just as a point, your highest level of abnormality is what drives your interpretation. So only one of these may be high level mosaics, but that doesn't matter. The fact that one of them means that that's ultimately driving your outcome, which is why your interpretation is high level mosaic. So for this one, for the polyploid 5, this is XXX. Now, you wouldn't see this on a genetic report, it would just say polyploid, but this is something that as of March 2022, whenever we get a PGT-A sample through the door, we can automatically detect female triploidy, which many technologies can't. So we're very proud that as of March, this is part of our standard PGT-A test. But the other thing I want to really point out is this complex kind of reporting. -15, that's chromosome 15, and chromosomes are split into regions. So this goes from the P terminus to the Q terminus. So this is Q24.31 to the Q terminus. This is a segmental change. So this is a partial chromosome change, which is mosaic. Here is another partial chromosome change, which is mosaic, and then a whole chromosome mosaicism. These are referred to as complex, and that is how they're also referred to in a lot of the published work. 3 or more changes equals complex mosaics. So the final bit of data from me before we jump to Tony is the seminal 1,000 mosaic transfer outcomes that was published by Bart et al. In 2021. And this really changed the world. And they came up with this stratification, euploid giving you a highest chance of success. This was across multiple clinics, but all using the similar technology to ours. These gave you a highest chance of success. And then you have these categorizations. Now, the patient in and of themselves aren't going to have this number of categorizations, but it helps patient management. So if we consider a euploid, it has the highest chance according to this data. A complex, so high-level mosaicism and 3 or more changes, we've really gone down to 13.2%. So not 0, but we can see it really dropping off. And this data was really helped with the patient management. But I'm not going to go too much into that. I'm going to let Tony really talk about the latest mosaic outcome data. So Tony, over to you.
Thanks, David, for that introduction. Yeah, this is a rapidly moving field, and just having come back from ESHRE, I thought we'd have a little update as well, because the amount of data coming out from various sources is great in terms of helping our understanding of mosaicism. Next slide, please, David. So this is a graphic that we show all the time, and this shows in green towards the right how the number of euploids diminish with maternal age, and in blue how the number of aneuploids increase with maternal age, and then in purple we have our mosaic results. And previously in things like the STAR trial, which I was part of, we would only consider euploids for transfer. And it actually has quite a big impact, because once you start considering euploids maybe first and then mosaics, it's a significant impact in the number of embryos you could consider to transfer. And I think, understandably, we've been very cautious about transferring these new forms of classification of embryos, mosaics, what to do with them. But, the data is coming along that's giving us a little bit better insight into how they outcomes are with these, and what we should consider with them. Next slide, please. It's also kind of quite an interesting field, because you kind of can get bogged down in the language a little bit. And this was a paper that came out this year, IVF outcomes with of embryos with abnormal PGT-A previous to refused transfer, a prospective cohort. And this was a paper from a group in New York who are transferring aneuploid and mosaic embryos, known aneuploids, known mosaics. And there was a rather headline grabbing article in the New York Times. Next slide, please. Study raises questions about popular genetic tests for abnormal embryos. And what they kind of mixed up in this is they mixed up what we would call kind of aneuploid and mosaics and classified them all to abnormal. And they went on to say that they reported births from abnormal embryos. But actually, you have to be very careful with the way you use language here, because what we can see already, and there's some really nice studies showing that if you transfer purely abnormal embryos, non-selection studies like Ashley Teague's study, they don't make live births. But mosaics are increasingly looking like they do at lower frequencies produce healthy live births than euploids. Next slide, please. So when we actually break this down and look at it ourselves, they had a large number of embryos. 23 were mosaic, 4 had a segmental aneuploidy, and then there was 9 with no results. And actually 6 live births from 23 mosaics is almost exactly the same as the PGDIS registry. About a quarter of mosaics are making a live birth. But then when we look at the full chromosome aneuploidy, next slide, please, you can see actually it's really poor choice to transfer full chromosomal aneuploidies, 106 embryos and only 1 live birth. And even then, it wasn't followed up to really confirm with genetic fingerprinting whether it was the right embryo transferred. So you can see that mosaics clearly are doing better than full chromosomal aneuploidies, and transferring full chromosomal aneuploidies, I think we can also is a pretty bad idea. Interestingly, this group in New York are going to keep on doing that. So we're there, and it does give some of the problems in this area that we use quite difficult terminology, because mosaics are a mixture of euploids and aneuploids. So we just have to be a bit careful with the language. Next slide, please. So I was fortunate to be part of this committee that set some of our first guidelines in the field back in 2019. And at that point, it was before we had the Viotti study, and before we had a lot of the data that we knew was coming along to say, this is how things are working. But it was a pretty good for the time, I think, statement. And it discussed, in context to what we know from prenatal biology, things might be more risky and you might want to consider transfers. Next slide, please. And it said, it seems to be relatively safe, although at that point that was with really little data, with low or minimal risk of negative outcomes, but we didn't have any data to say how often. Nevertheless, transfer of mosaic aneuploidies should be considered with expert advice and genetic counselling. I think that was a really great statement to include genetic counselling from that point. And I think it was very good for what we had at the time. Quite conservative, but a good statement at the time. And it did discuss low-level mosaics having better outcomes than high-level mosaics, and potentially ranking outcomes from euploid transfer first to mosaics. Next slide, please. And you know, we've entered quite a contentious field in mosaicism and talking about it, because different labs do different things in terms of how they actually detect mosaicisms and how they report them. And this was a really good study from Antonio Capalbo, and they did what is known as a non-selection study. So they transferred mosaics without knowing their, without the clinicians knowing their status, and then looked to see how many resulted in live births. And in their platform, below 50% mosaicism, they didn't see any difference between the mosaics and the euploids. And you know, they've gone on now to have that a recommendation in their testing, and other people are doing the same. We're not, and we contribute quite a lot of samples to the PGDIS registry, which I'll come on to talk about in a minute, which is a collection of outcomes from no mosaic transfers. And a bit like the Viotti paper that David showed, we see differences in low-level mosaics to high-level mosaics. So we still do that. And I think it can be quite difficult for clinicians and embryologists and patients to understand how different labs are reporting different things. There was a really nice paper at ESHRE from Mina Popovic looking at how mosaicism reporting varied, pretty much using the same platform, another platform than ours, over a large number of labs. And it's going to be something that I think labs are going to have to grapple with for some time. Next slide, please. So we are still here with the Viotti paper that David discussed, still reporting mosaics as to low level and high level. In this paper, they describe low level as 20 to 50, but we use 20 to 40, as we have done right from the start. And David explained a lot of this. Next slide, please. And, you know, there's some really great data coming out from this study, and this was presented at ESHRE. And you can see it's some of the things that are really important. You know, does mosaicism affect weight at birth, length of gestation? And you can see from this data, and we're starting to get some good numbers in here, you know, a couple of hundred mosaic transfers, or whole chromosome mosaic transfers. And you can see there's really no statistical differences, which is very good data to give us a little bit more confidence, to give people indications of what will happen after mosaic transfer. Next slide, please. So this was an update to Manuel Viotti. Now, the PGDIS Mosaicism Registry is a collection of known mosaic transfers with outcomes. And this was the basis of that 1,000 outcomes paper. And that 1,000 outcomes paper had about a third of those were non-selection. So that's good as well. This is collated by Manuel Viotti, who is a researcher at Zuva's facility in California. And he's been working hard on this, collecting from a good group of different IVF groups and labs. And they have been putting this together as a mosaicism registry, which is really good because we're building up our understanding pretty quickly. He gave an update at our annual conference in Berlin and another update at ESHRE. And from that 1,000 transfers, they've gone on to do over 1,700 transfers. About a quarter of them resulted in live births, a bit like that small paper from Norbert Gleicher I showed. And that trend that David showed of increasing load of mosaicism with lower live birth, that's continuing. And the thing that's really cool about this study as well, that they've been doing a lot of prenatal and a lot of postnatal testing. And in this study, they had found 2 pregnancies with abnormal fetuses related to mosaicism, which were terminated. So you can see this is beginning to kind of give us You have to do a lot of mosaic transfers before you find the ones that have consequences, abnormal mosaicism. And this is starting to give us some idea of the concern that we have in terms of how often mosaic transfers could have negative outcomes. Next slide, please. And this was their sort of data points of 364 pregnancies that either had products of conception karyotyping, CVS, NIPT, or amniocentesis. I think the only thing that I would say about this is if if it is an ongoing pregnancy, CVS and NIPT are probably not what we would recommend for mosaic transfers. Really, amniocentesis is the gold standard in this situation, primarily because CVS can still show what we call confined placental mosaicism. And also NIPT is probably not sensitive enough to pick up some mosaics, especially if you don't use NIPT that looks at all chromosomes, because some only look at specific chromosomes. But there's a good amount of data that we begin to get through here from the amniocentesis. Next slide, please. And this busy slide just shows you, actually, when you do this kind of testing in yellow, you do get quite a lot of things that are not associated with the mosaicism. So, you do get abnormalities that happen just naturally that are in the normal IVF population. And then you get things that can result in spontaneous abortion, again, that might not be associated with the mosaic transfer. And then at the bottom, we have two samples where the mosaicism in the embryo was reflected in the fetus. And actually, there's a paper coming out in Fertility and Sterility of a case that Cooper Surgical did in Canada, where we reported a mosaicism and there was an affected live birth. And I think there's only 2 or 3 now in the literature. So it's rare, but they are there. Next slide, please. And we've gone on with PGDIS to actually update the position statement. So it's changed a little bit. There's still this discussion of level of mosaicism from low level to high level. And, it's quite clear now that as your level of mosaicism goes up, you reduce your implantation rate, increase your miscarriage rate, and reduce your live birth rate. So the data is actually pretty solid and pretty interesting. There's kind of nuances that the new guidelines don't have, so they don't really give chromosome-specific guidelines like we used to in the previous guidelines. But I think we're coming to a pretty good understanding of what guidelines can be. Next slide, please. And then, this is just kind of where we are. And this kind of gives us a basis of, what they think that we can assist the clinician or the genetic counselor with. So embryos with high level mosaicism, less favorable outcomes than low level mosaicism. Experience on high grade embryo transfers is limited, and the percentage of mosaicism seems to be a better predictor of outcome than specific chromosomes, which is interesting because that's not the same with aneuploidy generally. So we're still beginning to understand, although we have 1,700 transfers, that's 1,700 transfers of 23 chromosomes. And actually, we're probably going to need 1,700 transfers of every chromosome being mosaic before we really understand that. And that's the sort of place where we are in prenatal testing, like amniocentesis or CVS. And, it does say a decision to transfer the mosaic embryo can be prioritized in the level of mosaicism or the type of mosaicism. So if it's low level or high level, or if it's a part of a chromosome mosaic or not. So these are some pretty, I think, much more definite guidelines than we started off with a couple of years ago. Next slide, please. So just in summary, mosaicism exists, although on different levels on different PGT-A platforms. And that's something I think that we're going to have to understand in the future. The PGDIS Mosaicism Registry indicates that live affected pregnancy or live births are rare but not unknown. Mosaic embryos can produce live birth rates, but a lower rate per transfer than euploid embryos. And I think really importantly, mosaics with appropriate genetic counselling, and at Cooper Surgical, we do offer genetic counselling to assist clinicians and patients, and proper prenatal testing, preferably amniocentesis, that can be considered for transfer. I think that's the end of my slides, David. Yeah, so with that, I would like to welcome a very patient Dr. Bart, who's been listening to this.
Just before we do that, just a reminder to people to please, if they have questions, can you put them in the Q&A dialogue? We've seen a few hands being raised. If you could ask your questions in the Q&A box, that would be helpful, because we can't actually hear you. So,
thanks,
sorry.
David. No, it's good reminder. So, Dr. Bart, perhaps you can give us a little bit of background on embryology, IVF, where you are, particularly at the with respect to Beacon Care and your background in PGT, and give us some idea where we are with how Beacon looks at mosaicism.
Good afternoon. Thanks for the invitation for this meeting. So I do IVF since 2011 or 12, so it's 10 years for sure. Last 6 years here at Beacon Care Fertility. That was the reason why I chose this clinic, and the reason was genuinely, the ability to do the genetic testing of the embryos. We realized, we knew it for a fact for a long time, that the most common reason for IVF failure is chromosomal abnormality of the embryos that we're transferring. And it was basically based on some sort of, I don't know how to call it, intellectual arrogance, that since transferring abnormal embryo doesn't kill a woman, it was well tolerated. But on the other hand, it didn't give too many live births as well. So our clinic is small in size. We are doing, under 1,000 cycles, few hundred cycles a year, but 70 to 80% of our protocols are based on genetic testing. Most of it is sold PGT-A. And in parallel to that, we do also PGT-M, PGT-SR, cooperating with CooperGenomics since the clinic was set up 12 years ago. So currently we are doing in the range of 1,000 biopsies a year, and that's where the results are obtained for our patients' benefit. How we counsel patients, perhaps let's start with a few general medical remarks. Mosaicism, which is the topic of today's meeting, is to a degree a tolerated natural biological event, and say healthy human liver has 30% of hepatocytes mosaic. 2% of people, so 1 in 50 individuals like us sitting here, can be born from aneuploid placentas. So confined placental aneuploidy, which Tony mentioned, is present in 1 in 50 live births, which also gives the answer why CVS is not such a great tool, although, for the most of it, it is sufficient. But embryos that were PGT-A tested won't benefit from repeating essentially the same test in a way. So the patients who come to us age-wise, they are between 30 and 39 on average, and this is the reason why we focused on, incorporating this technology to our clinical practice. Most of embryos that people produce are abnormal. At this age, the cutoff for normal versus abnormal, 50% would be between 35 and 36 years of age. So, if you run a clinic where average patient's age is 32 years old, the utility of this practice is debatable, although it's not bad. Whereas with our patients, the risk of miscarriage, risk of delivering an unhealthy child, they are increased, and it's a natural consequence of these facts, basically. So patients come into categories. One, people who learned about us, learned about the technology, who, IVF patients usually peregrine between the clinics, but they already know what they want to do. However, 90% at least of them lack, background that Tony would have, and you really need to be an expert to understand all the facts and figures related to mosaicism specifically. So we inform our patients at the initial consultation since they want to do PGT-A, what categories of results to expect. Normal, abnormal, mosaics, no result. These are the most common that we have here. The normal abnormal is clear to understand. The mosaic is something complicated enough that I personally tell my patients, once such an embryo arrives, we will have a special pathway for you, because these embryos are composed of both normal and abnormal cells. Most of them can be safely used. And I always use an example of a clinic that has no access to technology or doesn't do it for other reasons, that they are transferring, not knowingly, mosaic embryos, and they did not bring any new disease to the world. Most of these embryos are safe to be used. The problem is that as much as liver can tolerate, mosaicism, patient's brain cannot. The idea that they come to have a healthy embryo, one transfer, one healthy baby, is so strong that it is difficult in patients' management to advise them or to make them use this embryo. I mean, you won't enforce this idea, but that's the whole point in more teamwork, where the detailed, exact information is given by the CooperGenomics. Every patient who has a mosaic embryo and would consider it for transfer will be provided a remote counseling for their particular circumstances, and they can then make an informed decision. And obviously in the clinic, we have an algorithm of embryo selection where Euploid comes first, low-level mosaicism with a split of segmental and complete, then high-level, going down to aneuploid embryos. I, for a fact, remember 3 patients. We have 3 children born from mosaic embryos. We transferred few more. I won't tell you how many, because we are a practice of four clinicians. But generally speaking, most of these embryos are left intact, and patients would really regard them as a last sort. Most of patients, if ever they can afford another IVF cycle, they would try to make a new attempt and identify a euploid embryo before using a mosaic. So this is how it looks in clinical practice. You're right about the paper from New York, and Norbert Gleichers from CHR stands on euploids and aneuploids and mosaicism. And I think a lot of bad press that you might be exposed to initially came from the terminology mix-up, where euploids were one category and everything else was aneuploid. And these aneuploid also had embryos with a live birth potential, and that's where there is a role of clinician to advise patients of it. Now, we cannot do more than advising of it, because these pregnancies are pregnancies of higher maintenance, and they will be always advised to do further follow-up. They will be advised to consider amniocentesis to confirm the inner cell mass component of mosaicism. Is it clean or is it not clean? So that's always a bit frightening. People want to have least concern with the pregnancy, and I think these are the most desperate couples or scientists themselves who would be confident that use of a mosaic embryo is fine for them. That's clinicians view. Proportion wise, most of patients will produce normal embryos rather than mosaics, and it's really I would say marginal, but it's a minority of patients who will be facing this problem. I think for most of it is like 3-to-1 relation between mosaicism and euploidy. For 3 euploid embryos, you will find 1 aneuploid, one mosaic with potential to transfer. And obviously, we follow, our colleagues from CooperGenomics advice that essentially half of mosaicism, whole chromosomal mosaicism, are bad prognosis and not suitable for transfer, really, which patients will be made aware at their consultation. So this is how we work with mosaics embryos. It's always the known unknown, and I think people prefer ignorance rather than knowing. So if you were to face, you know, an untested embryo which was not suitable for a biopsy versus an embryo that you know that is carrying some sort of anomaly, it's individual choice, but most of patients will choose the embryo that is more unknown than known to be carrying something. So I think that would be the most of our experience.
Yeah, it's fascinating to hear, you know, you talk about that, and you've picked up one of my favorite Donald Rumsfeld's phrases, the known unknowns. And it must be hard though to explain to patients that, you know, this is a biopsy and it's a representation of what is in the biopsy, and you're kind of then implying what it is in the rest of the embryo. That's a hard concept to get across to patients.
Well, yes, but you know, if patient is willing, I wouldn't say capable, but willing to explore more on the biology side of it, most of people don't. They don't have, you know, the basic knowledge from college or from high school about it, but you have to develop some background for them that, you know, it all comes from one cell initially, and it's somatic, you know, problem that it's after the egg was fertilized, it produced two, at some point it produced two different cell lines, one of them carrying the abnormality. To what degree this abnormality affects the functionality of the whole embryo, usually it doesn't until you know further that we can observe it safely in the lab. And then that's the problem, is that, you know, embryo is, I would say, use a smart concept, but embryo has the ability to self-organize, as you know, and it can expel the cells that are usable, however not the healthiest, to the outer, to trophectoderm, retaining the normal cells within the inner cell mass. To what degree embryo is capable, particular embryo, doing that in the particular, you know, mosaicism or aneuploid, we don't really know. Now, you don't see my walls here, but I have some artistic impressions of the embryos here on the walls. So we go with patients, like, you know, showing them step by step what's happening during the process and at what point these changes might have happened, and how the embryo might be, let's call it disease-free, despite being diagnosed with some sort of mosaicism in the trophectoderm cells.
Yeah,
but it's usually, I can tell you, it usually exceeds normal patient's attention capability, because a general IVF consultation takes anything between, you know, 20 to 30 minutes. On top of that, if you want to develop, you know, some idea, some knowledge about embryo biology and then genetics, it's too much. We also run patient satisfaction survey. If ever you embark on these details, patients always complain about it in a way that they don't understand what I'm talking about, because this is scientific jargon that people are far away from.
Yeah, no, I can understand that, and it's obviously a high pressure situation for patients to make those kind of decisions. And we occasionally hear, kind of interestingly, about patients who say, well, I want to bank my euploids because they're the ones that are guaranteed. Yeah. Can I transfer my mosaics first? Have you experienced that as a conversation?
No, I have not. This is a new thing to me. You know, our history is like, you know, until 2 years ago, Ireland was a country that did not allow, you know, abortion, and it was part of the thing. And we got it from our patients. Their understanding was that they're coming to do PGT-A as a proxy to limit the risk of medical abortion, because, you know, of the age. You know, if you're 42, 43, the risk of a Down syndrome child is above 2%. Any chromosomal abnormality is above 3%, and that was their first intention to do this treatment. It's changing a bit now, but nobody came with the idea, let's use the less abnormal first, retaining the normal embryos for future. That's not something I meant.
No, it's an interesting concept that we've heard from a few people. It's really interesting because Ireland seems to be progressing, whereas, you know, Wade versus Roe repeal in the US, they're going back the other way. You know, I'll not ask you to comment on that because it's quite a complex subject, but, you know, it's a difficult subject for mosaics, particularly. You know, if you don't have laws that ban abortion, And, you know, it's interesting to where we are now. You know, we started off the first report, David mentioned it back in 2015, of mosaic embryos, you know, when the technology first came along as sequencing, and you have that fantastic double-edged sword of, oh, look, it's really good, it's really sensitive. Oh God, we found something else, you know. And I think that's interesting. And how comfortable do you feel? How much data would you like to see? You know, we're 1,700 known transfers, a couple of papers of embryos that have resulted in affected children. You know, do we need to be where we are with CVS and amniocentesis, hundreds of thousands of cases, before we can really be more informative for patients?
Well, I think, you know, your access to the PGDIS data is most important, and this is part of teamwork. Okay, being a clinician, I will have no time. Not that I have will, I do have a will, but no time really to develop this knowledge on top of what I already know. Just, you know, incorporating PGT-A as a routine practice, knowing its whereabouts is, you know, subspecialty in subspecialty already, and following up on data of each of the individual chromosomes, mosaicism. This is not the case. This is, I think, your job. My job is to tell patients that there is a safe way of analyzing this embryo without, you know, attenuating any related risks, and what would be the ways of minimizing it further should the pregnancy resolve. As amniocentesis, chordocentesis might be exactly the same for that purpose. Although I met patients, good few patients actually, that did the NIPT after being told that, you know, this is actually the same. It's not exactly the same, but basically it's looking at the same set of cells from the trophectoderm. They did it on their own. They did it for their own sake. I mean, it's always reassuring to hear that from them. But patients, again, they spend money on it, and they should be informed that it's redundant.
Understood. David, do you have the next question?
So I was actually, it's kind of an update and a question wrapped together. So thanks for all those who did the survey. So from those who answered the survey, 60% of the respondents said they would transfer a mosaic embryo, which is fantastic. And 90% said they really like the transparency in mosaic reporting and they want to get mosaicism. So I suppose, you know, there seems to be a section of people who like the mosaic reporting, but perhaps are a little uncomfortable in transferring that mosaic once they've got that information. So I guess the question is really on how do we keep people talking about this and perhaps move the field forward to be more comfortable in transferring mosaics? Is it something which you feel you need as a clinic to kind of do yourself and get comfortable with, or is it a community action? It's a bit of a long-winded question, I know, but what are your feelings on that?
For me, it's a community action. You know, we are working in highly technological medicine. It's not, you know, an individual doctor's practice with a usual lab for bloods. We are having, you know, lab practitioners who do embryology for us, and then there is a secondary lab which is you know, yours, and everyone has a say. Usually in normal IVF clinic, like let's say IVF clinic that doesn't do PGT-A routinely, you will rely on embryologist's opinion about the embryo quality, although it is subjective to a certain degree, right? And patients, then you have to deal with patients distraught why this beautiful, you know, AA day 5 blastocyst with 100% survival upon thaw did not result in pregnancy, telling them, well, you know what, it's most likely abnormal, which is entirely true. Statistically, it's more likely abnormal than not. So we have to rely responsibility and share responsibility rather than taking everything on one, you know, business end, which is the consultant's desk. So that's why, you know, extending the embryologist advice on the embryo vitality, its quality, as we know them by Istanbul criteria. The next step is the genetic reporting and the follow-up if the genetic is not standard, because let's say mosaicism reporting is a non-standard type of report. you need an expertise to follow up on that. The access to clinical geneticians is very poor, and they have no time to do such things. This is really for a special unit, like, let's say, somebody who does this post-testing counseling to advise patients about particular embryo.
That's all very fair points. So I think we are approaching the top of the hour, as we would say. So Tony, do you have any last question? You're muted, by the way.
Oh, you'd think I'd be used to webinars by now. Damn. Yeah, I had a question come in that asked about false positive, false negative rates, and this is clearly an interesting issue for mosaicism, because we're taking a biopsy and it's 5 to 10 cells out of 120, 130 cells of an embryo, and how representative can it be? Well, it is tricky to do that, because we do know that you could have something that is a euploid biopsy, and it could be a mosaic inner cell mass that could produce a mosaic live birth. We've been doing PGT-A for about 10 years now in the UK, and in that time we've had 2 POCs that have come back to show that they're mosaic when we reported them euploid to start with. So that's fairly low. The one that's hard to do is to say, if we called it mosaic, does it actually result in a mosaic, or do you get false positives? And honestly, the only way that we're going to be able to work that out is as a field, in terms of doing lots more transfers of mosaics where appropriate, with counseling, with follow-up, and seeing how that happens. Because as Dr. Bart said, confined placental mosaicism is a feature we know, and embryos can either self-correct or apoptose those mosaic cells, and they can become effectively euploid. So that's going to be an interesting one that runs on and on as sort of questions. So that was the question that came through that I was just going to answer from the technical point of view. David, do you have any others?
No, I think that's great. I think we've kind of exhausted our time. So unfortunately, whilst some of us could keep talking about this for years probably, and will continue to talk about it for years, we should let people get back to their proper day jobs. And so I'd just like to thank everybody for attending, and the team behind us who've organised all this and pulled it together all so well for us and allowed us to present to you today. So yeah, I'd just like to thank everybody. Emily, were you going to say anything?
Yes, I'd like to thank you, David, and Tony. We've had a few really kind comments come in saying what a clear explanation of mosaicism this has been. So thank you very much for presenting on that today. And also big thank you to Dr. Bart. I think it really brings it alive for our delegates when they can hear about real life experiences. So really appreciate you sharing your experiences today. Thank you so much for joining us. It's been brilliant.
Thanks for having me.
Oh, that's our pleasure. Thank you also to Tenna, who you can't see, but Tenna is our marketing manager. She's there behind the scenes organising us all and making sure this runs smoothly and promoting the webinar. So thank you very much. If there are any other genomics or lab or theatre procedures or aspects of fertility that you would like us to cover in a webinar, please do let us know. We take requests and we welcome requests. We'll be running more webinars in the autumn, so get your requests in now. You can either contact your account manager at Cooper Surgical Fertility or email us at customerserviceuk@coopersurgical.com. And you can keep up to date with our webinars and all of our face-to-face events, also by signing up to our fortnightly bulletin. And again, if you want to sign up to this, you can do this by sending an email to our customer services team. That email address again is customerservicesuk@coopersurgical.com. So it just remains for me to say thank you very much for joining us today. We had a bumper attendance today. It's been a really interesting and fascinating topic, and I feel that we'll probably return to mosaicism sometime in the future. So thank you very much. Enjoy the rest of your day. Try and stay cool, and we shall see you again soon.